start off with our first speaker, Steph Bramley, who will be presenting on the evaluation of the Mental Health Navigator scheme.
Hi, so good afternoon, everybody. It is a real pleasure to be here and to see so many lovely faces in the room. Face to face! Yay! Yes, thank you, Laura. So welcome to my talk. It's an overview of the evaluation of the Wakefield Mental Health Navigator scheme. I'm Dr. Stephanie Bramley. I'm a research associate in qualitative methods at the University of York in the Department of Health Sciences. So I'm a qualitative researcher, as I said. My background is mixed, so background in music psychology and also gambling behaviour, so the impact of gambling for vulnerable groups. But here I'm talking to you about this evaluation. So before I start, you might notice that I'm not Sarah. Sarah is poorly, unfortunately, so I'm stepping in, and these are her slides, so allow me that grace, if you will. And my colleague, Dr. Sarah Macefield, is also here. Give us a wave, Sarah. She's right there. So Sarah's going to helpfully answer any quant questions that you have. So no pressure, Sarah. So we're about halfway through the project now, and I'm going to talk about our plans and our emerging findings. So first thing to say, this is very, very much a team effort. And our team comprises researchers from Newcastle University. Sheena's in the room. Hello, Sheena. The University of Manchester, and also colleagues at York. We also have a number of policy and practice partners, so Wakefield District Housing, who is implementing the the Mental Health Navigator scheme, Wakefield Clinical Commissioning Group, who co-funded the scheme itself, together with South West Yorkshire Partnership NHS Foundation Trust, and Gresham Borough Council down in Kent, who were intending to set up as a new site in the new year. The operational team consists of myself and Sarah and Sheena, and Sarah C, Sarah B, the PI, and Lois. As you can see, I'm surrounding with Sarahs. But essentially, we are an amazing group of researchers and early career researchers too, and it's a pleasure to be involved in the evaluation. So our original idea was to have a comparative control site, but we realised that that wasn't feasible. So the Mental Health Navigator scheme is very complex, and the idea of bringing in a core site wasn't ideal. However, Wakefield District Housing, they got in touch with Gresham, and like I said, they are interested in hoping to implement the scheme for themselves later on, so hence their involvement as well. So let's put mental health and housing into context. So as you can see, the figures from Mind on the screen there, more than 2 in 3 people with mental health problems have at least one issue with their current housing. So there's potential a bidirectional relationship here where people experiencing mental health illness may be at increased risk of housing instability and vice versa. Therefore, maintaining a tenancy whilst experiencing mental health difficulties is challenging, yet few people with even severe mental illness live in supported housing. Most of them rent their homes. But on the flip side, we know that if we have high quality and stable housing, then that is key to maintaining good mental health, and is also important for recovery. Stable housing helps people. It helps them to access formal support services and maintain their independence. Also helps to help them to build good relationships with their neighbours, and in doing so, it improves access to more, say, informal social support. So helping to improve the stability and quality of housing is key in efforts to improving mental health outcomes. Despite this knowledge, it appears that housing support officers might have few resources or find it difficult to find resources to deal with mental health, and particularly in relation to tenancy problems, meaning that these can quite quickly escalate to people being in crisis or terminated tenancies. So moving on to the scheme itself. Wakefield Mental Health Navigator scheme was developed in 2015. It was jointly commissioned, as I mentioned before, and it comprises of 3 mental health navigators who are employed by the local NHS trust but are embedded within Wakefield District Housing. They are skilled practitioners, so it could be a social worker or a mental health nurse or an occupational therapist who act as navigators. And the Navigators provide support to tenants with rent arrears, emergency tenancy issues, antisocial behaviour, housing management issues as well. And it can be people within Wakefield District Housing who refer tenants to the scheme. So it might be that they become known because a member of the estate staff has visited them and noticed something. The Navigator model provides tenants support to tenants with if they have mild to moderate mental health issues, and with support to access mental health services in order to, as I say, prevent housing issues resulting in tenancy breakdowns. A previous evaluation of the scheme back in 2016, so about a year after its implementation, produced some promising impacts that the scheme could help improve outcomes for tenants with mental ill health if implemented more widely. That evaluation had some limitations. So, for example, planned analysis of routine data were not achieved due to a lack of study planning, and social outcomes and consequences were not measured well. And there was also a lack of insight from WDH staff themselves. So we're now 7 years later, and further evaluation is needed. So it's the evaluation is funded by the NHR Health and Care Inequalities Consortium. We had a project team in place from January this year, and the overarching aim of the evaluation, as you can see on the screen, is to conduct a robust, theory-informed evaluation of the Wakefield Mental Health Navigator scheme, whilst exploring potential barriers and facilitators to adoption in novel settings, and using that evidence to inform an implementation toolkit to support rollout in other sites. And so this piece of work is broken down into 6 work packages. And the study is designed to move the evidence base on for the scheme. We want to generate learning to inform a toolkit for those interested in adopting a similar scheme in the future. I need to make clear that it's not an effectiveness evaluation, but we are exploring outcomes and costs and economic factors in more detail that has been done previously. So in terms of the methods that we're using, as I said, we've got 6 work packages. The first 2 are quantitative, 4 in fact. First 4 are quantitative. So work package 1, we're analysing routine outcome monitoring data that is routinely collected by WDH. It's descriptive analysis, and it's probing the characteristics and circumstances of tenants, understanding experiences of the scheme and outcomes. It's all anonymous data, and we're looking at a sample of about 360 to 400. Sarah M's nodding, so that must be right. Work package 2, it's also quantitative, so we're going to be doing an analysis of case files or case notes from tenants, and these tenants have provided their informed consent, so it is identifiable. It's a sample of about 30 to 60, and to do that, Sarah M and Sarah C are going to do a qualitative comparative analysis and exploring essentially mechanisms of impact of the scheme. For work package 3, we're conducting an area-based analysis and interrupted time series analysis using statistics such as the hospital episode statistics to see if there's any effect on that data. And then for work package 4, we're simulating data collected for work package 1, 2 and 3 to inform a cost consequence analysis and a broader assessment. For work package 5, that's the one that I'm leading alongside my colleague Lois. And we're going to be doing qualitative interviews with stakeholders. So approximately 40 people, 20 tenants and 20 professionals. The interview schedules and topics are going to be guided by normalisation process theory. And essentially what we're trying to do is assess their thoughts, their views, their opinions, their experiences, and most importantly, their reflections on implementing the scheme. And let's face it, we all want a wish list for the future, don't we? So there'll be a bit of that as well. And then work package 6, we're going to combine everything we've learnt in the 5 preceding work packages to produce a toolkit. So this is going to be an implementation toolkit, which we hope will help people to think about their own scheme, what adaptations might be needed for implementation in other sites, for example in Gravesham. And to do that, we've set up an implementation advisory group. So in terms of our emerging learning, We've only just received approvals from ethics, and in the last week we have started participant recruitment and data collection. So in this, I think it's worthwhile just to focus on our learning in relation to setting up the study, because that's where we are at this moment in time. So in terms of approvals, our data spans NHS and non-NHS organisations. So it has been a little bit complicated in terms of who owns the data, developing data sharing agreements, data protection impact assessments, but this has been really helped by a lot of reconnaissance. We've had to establish what data is collected by whom, its format, who has access to it, and we've done this by having regular meetings with WDH, who I have to say have been completely on board with our evaluation, and we couldn't wish for better partners. And themselves are actually on their own journey, so they are having a moment of reflection to see whether their systems that they have in place are fit for purpose and help to evaluate their own scheme in the way that they would like to. And we know that these challenges do reflect wider sector issues, particularly within housing, and HACT has commented on that there is general a lack of standardisation of routine data items and formats, and they themselves are pushing for a core outcome set in relation to housing. With regards to the theory of change, we can celebrate some success, and we really do mean that. It didn't exist. So it's been developed in partnership with WDH during a workshop and ongoing conversations. And essentially, we really did have to get back to basics and establish how the scheme was intended, how it's evolved over time. You know, we're 7 years down the line now, and its natural evolution. And for example, WDH have actually acknowledged that there has been a shift and a bit of a drift. For example, they accept referrals from people who have tenancy issues, but not mental health issues, for instance. But nevertheless, they feel relevant that the Navigator can help and support them, and so they're accepted onto the scheme. The theory of change is designed to describe and understand the mechanisms which make the outcomes happen, and it's also been helpful to explore some dark logic and potential harms stroke unintended consequences, and our PCIEP group have been particularly helpful with that. As I said, we've got insights for potential new adopters who are also on our implementation advisory group. And whilst we were waiting for approvals, we thought, let's do a scoping review. So if anybody's interested, I'm running out of time, but it is registered on OSF. So please do check that out if you'd like to. So our grateful thanks, and we really do mean this. Thank you to the funders. Thank you to WDH, who are enthusiastic in their support. They've given a lot of time for meetings, for training. They've been open and willing to take part. They provided all the help and assistance that we've asked for, without questions either. That's really helpful. Swift, who have been helpful in supporting our study approval process. Our PCIEP group, made of 10 members, 5 professionals and 5 people with lived experience of housing instability and mental health issues. The NIHR, of course, and the consortium, especially for putting on this wonderful event, and our study participants, who I think my colleague should have interviewed one today. So we might have our first study participant today. So here's to that.